but it doesn't seem as many to remember. All right, go ahead and raise that leg up for me. All right, now her, I'm gonna pop you down. Okay. I'm not gonna fit her all on one, okay? This is where we're gonna take her, take this, and I want joint to joint. Okay, I usually, when I'm dealing with my patients, I'll feel right here on the sides here, your femoral epicondyles, or the femoral condyles themselves. You can feel them on her right here. I know I have them here, but I also have patella, right? Please don't do this to your patient. I show you what not to do, don't do that to your patient. So here, this is where I'm gonna show y'all if I do standard 40. Fix just a second. They can dorsiflex their foot a little bit. It is helpful to keep them aligned when we dorsiflex. Okay. All that there. Okay. This is actually close to 41. Okay. I'm still not getting everything. And even if I did come down just a little, I'm still not gonna get everything. Sorry, we're gonna go up. See how my beam is spreading? Okay, but I'm still gonna have to collimate side to side, leave the top to bottom all the way open.
We could also move the table down, right?
Yes, but it's of collimation and moving my collimator box is all I'm doing now.
But for someone like me who then has now gotten too
Yeah.
to do anything with, would just
I will
move
come in.
the table down.
I will come in to the skin margins if I can. Again, you will have some of your patients, their calves, muscular calves tend to either side equally, but you'll have those patients who it seems to move to one side more than the other. Remember, tibia runs down the center. I'm centered on the tibia.
Those
Okay.
patients that have smushier calves.
Yes.
That's very
Is it
gentle.
okay if we don't get all of?
You still need, you need the soft tissue. We still need soft tissue.
So if it's like the big patient, you gotta.
Yeah, they still want soft tissue. So, yeah. All right, but I usually have my light field where it's hitting malleolus. And even then, I need to come down just a touch to make sure I'm truly centered. And if I've maxed out and I really want to go in, I'm bring the table down a little bit. Okay. Got that light field, and I'm actually at 47 right now. 47 to 51. Typical, obviously, unless it's a pediatric patient. I could probably get in under 44.
Oh, 10 by 12.
I don't
Yeah,
know.
but so
we're the
is
same
she.
height. We're
You're not the same height.
No.
Okay, how tall are you? How tall?
You got baby limbs.
I'm just kidding.
I was like,
I thought you were
That's 4
shorter.
inches.
I thought you were
No.
shorter.
No. So, all right, so I got,
Because you're always seated.
I make sure I have light field above the patella. That ensures me that I have joint space. Because remember, patella's the shield over the joint space. I make sure I have that there. I can see I got here. The other thing too, make sure the cassette itself is point to point, because I will see this a lot where they cover this one and they don't move here. So I'm gonna do this, and I make sure I have shadow here and here, and I've got what I need. Okay, so be mindful.
Where are you aiming for down here? To make sure you get enough angle.
So I make sure I have light field below the malleolus,
Okay.
well below both of them, because I usually shoot for this one. And if I have my malleolus in the shadow, we're okay. But that's the other golden thing too, is even if you do have a patient, you're like, dang it, it's okay just shoot an AP angle real quick. So, and sometimes them flexing it brings it in. It's weird because she could do this right now and it just throws it off, but as soon as I do this, it brings everything into perspective. As soon as they flex that foot. I gotta move her just, there we go. Now I got her in. Just be mindful of shadows. That'd be for your AP tip fib, okay? All right, from here, just gonna roll it to affected side. I try to have this right here, Sims position. I try not to have them rotate too far forward because you can end up with like that. We don't want that.
Mm-hmm.
Can you come back?
In just a second. All right, I'm gonna angle her just right. All right. Again, I'm going down the tip fib. I get a lot of this. Or I get this, and they're still not there. Rule of thumb too, if it's not a bad idea to try and line towards your malleolus. Again, I want to match. This one you end up being actually just behind it. This one, when they are positioned properly. I look up here at shadow. I have shadow of my knee right within that border that I need it, okay? I look for that. So I know I've got joint space. Even though I've got the crease here, I still wanna make sure, okay? And here, I have light field below here. So I can actually, instead of, because I'm already maxed out, go a little bit beyond. We actually can go a little bit beyond the 17 on this one. That's the one thing that's nice about tabletop. You can these are the ones you can eyeball.
Mm-hmm.
Doesn't have to be perfect 10 by 12. Doesn't have to be perfect. Again, what are we imaging? Do we have everything collimated openly and where we need everything? Okay, so at this point, I will actually come in. Usually, I'm going to come in to right close to the skin border here. I still have shadow here, and that's going to be for lateral tib fib. Yay, paying attention, I like it. Not in the shadow margins. Not in the shadow margins. I see that a lot. People forget, they throw it in there and they're not, then they go like, you got tanked. So, yeah, okay. Happy for lateral tib fib. Just AP and lateral, just those two projections. We have 2 projections for your tib fib, 2 projections for your calcaneus, 3 for the foot. Technically 4 for the ankle, but standard practice and even in every day it's just 3 views. Okay, but I showed y'all 4. Huh? I gotta do calcaneus. Alright, so I'm gonna actually have you set up for that one.
Okay.
Alright, questions so far?
Nope.
This one I feel like is the most. This is one of the more simple weeks.
Oh, I loved first floor
This is
counting.
one of the more simple weeks. Alright, so for calcaneus, I am gonna need my 10 by 12. Here. What's in my mind? It's okay. Alright, so this one I am gonna have to go this way. So I'm gonna move her. I'll go ahead and move my table this way. I'm gonna slide you. Come towards me.
Down?
Yep. So at this point, this is where I was telling y'all how they had her, how we always tell y'all, center them to the cassette. This is the one time you're not truly centering, okay? 2 finger widths, bottom of the cassette, okay? So from here, I get her centered as much as I can onto my cassette. Okay. All right. Now, go ahead and get to my 40. I am coming towards y'all now. So y'all might want to come over this way a little bit. All right. So rule of thumb when you're doing calcaneus, start low. Start low, okay? I will get little things done. Start before I see I'm way high here. Obviously, I'm hitting toes. So we have, I think I have it over here this time. I will have straps for y'all. I have a set of restraints that, and they're gone. Okay. Find this. Actually, I think I have-
Do you want
So you don't
to use
change.
the strap from this?
That nickel.
Here it is.
About a nickel for every time I run out.
That's 1 nickel.
All right, so this
It's a lot of nickels.
cross toes, grab them here, have her pull her foot. See how now, where I was hitting here, I'm hitting here, okay? But now look where my crosshairs are hitting pretty close to the center. Okay, that's where it's actually gonna project this image. When you are placing your marker, do not put that here. It will get projected in the center of it. You have the best, beautiful, great, place to the side, okay? So this is where, right now, obviously I am gonna collimate down a little bit. This is the one where I'm gonna have light field up here, okay? And now, toward the center of my set, I'm actually at 41 right now. Gotta be between 40 and 47. Okay, so I'm gonna leave it there. And I'm gonna come up just a little because I wanna be right about the center. Move that just a little. Center just a smidge. Okay. Now you're still technically going through the base of the third with this, even though you're aiming for joint space. So I'm gonna come up just a smidge. Okay, right about center here. I'm still pretty centered to where I need to be, okay? Bring this here, and I'm still at 41 inches. Some of y'all, if you get it right at 40, times I get it at 40, as long as you are not beyond 47, okay? I give y'all a little bit more because y'all are learning right now, and it's kind of a big, this is the one you save to last, because this usually takes the most time. But if you push your table fairly back, like this, put her to the end of the table as well. Start your tube low, because the worst thing you do is you're either moving, I see too much of this, where they're moving table and tube at the same time. You're gonna mess yourself up. Do one at the time. Always start low with your tube, because worst case, you're either too far out, then you just bring her closer to the tube. Does that make sense?
Mm-hmm.
I know it takes you a little bit longer you don't always get first aid.
It's fine. It's fine.
But we'll have these for them to pull their feet back. But this is one right in here. Okay, that's for your AP axial, planto-dorsal projection of the calcaneus. Just relax. Okay. All right, I'm gonna take this away. That would be for that. Questions? Again, always start low. I see a lot of students start high, so all of a sudden they're like way up here. They're like, man, why is dang, I'm at the table. What's going on? And their SID is 50 something, and I'm like, what did I tell you to do? Always start low. It's easier to start low and then work it up a little bit, and then I can move her closer to the tube if I need to. Okay, but when you're doing your SID for these, it actually should be to the center of the cassette, not here. It should be to the center when you're doing the SID with these. So, all right, questions before I do lateral calcaneus? This is a light week for stuff. All right, so she's pretty much here. If your patient is comfortable like this, you can do your lateral like this. Now, when you're doing lateral calcaneus, whether you want to match the axis of the foot, whether you want to do it this way, or whether you want to do it this way, cassette direction on this one, we don't harp so hard on as we do with everything else, okay? So, I'm going to center the calcaneus here. I still need her in a true lateral, okay? I don't want to see her like that. I don't need to see that. So I want her in true. Dorsiflex the foot. Get her nice and centered.
Don't hit her in the head.
Oh, thank you.
You okay if they sit like that and not way down?
Yeah. If they want to sit, if they're comfortable even sitting like this when they're doing your tib fibs, that's fine. They can do that. I have patients who are like, I can do this. I can do this. It's like, I don't need you to do that. I need you to do this for me. It's like especially the 90-year-old grandmas who like to put their feet behind their head. Those are hilarious. I'm like, okay, I'm glad you're still flexible, Grandma. All right, find the malleolus. We're going 1 inch distal. Just going distal. Not going down. Wrong one. Dang it.
There you go.
Jesus, I'm having issues today. Oh, I'm out of table.
Give me a concussion.
You're welcome.
Do you get
If your reflexes are
Not only
not
like that
good
too,
by
was too
now,
close
This is wet.
for comfort.
This is my life.
You are 2 weeks away, ma'am. 2 weeks.
And then I can
Knock
be
all the
older
knowledge
if
out.
I got a concussion. So.
I'm not trying to concuss you today. All right, so here.
Not interested.
All right. So, all right. I'm the weird one. I will put the malleolus right here at my hip joint and go to the tip of my thumb, because that's 1 inch. I'm the weird one that does that. So that's what I've always done, but it splits out your calcaneus fairly well. I include, now here, this is where we can come down. I will open up a little bit further up front. I try to, when I'm doing this, I go to the tissue margin here. Yeah, you want to make sure you have navicular. I go basically close to the tissue margin here. I'm well above here. If I feel her little ridge right here, I'm fairly certain I have navicular in there, okay? So I can actually do that. I can come in a little bit more, but have navicular in there. 1 inch distal, and it just sections out your heel really well. So this one here, you usually have enough room to pop it right there. Some of your techs will throw it back here. More power to you. I do not recommend that. But come forward just a little, pop your marker. That's another reason why I switched to the aluminum markers for you guys, because they are skinnier. It allows you to collimate a little bit tighter,
Did you guys
side
get
to
your
side.
aluminum markers?
Not yet.
Oh.
They'll be getting those soon. Getting those soon. I finally just got the other ones in, since some of you like to lose them.
Yeah, my bad.
So,
At least I
ouch.
told you in
It'll
advance.
smack my head.
Throw it on the track.
Again, true lateral. So to actually have her in a true lateral, your heel is not truly going to touch the barrel in it. So if I have her come down just a little, come up just, I'm gonna get you in a true lateral one real quick. There we go. Heel barely touches. And it's really, it's like maybe 1 millimeter, 2 millimeters at the most. But to get her in a true lateral, I will have to, I forgot about that part. Get her distal there. Got my marker in there. Sorry. So.
It hurts my hips.
Dorsiflex that foot a little bit. There you go.
Yes.
I gotta find that happy medium. This is that
Do
happy
you want my
medium.
toes to be in line, or do you want me to have a flex?
There you go. All right, there we go. Marker.
Get your back to school shopping now.
Make sure. Yep. You gotta contort them in all kinds of funny ways.
Okay.
But for a true lateral calcaneus, the heel heel is just barely touching. So that'd be for your lateral calcaneus. Now, Mr. Gardner, I will show you how he does his. Because you end up clipping too much. His is more what we would call seasoned.
Yeah.
So he takes this, he finds here, and he goes this way. He goes 1 inch diagonal instead of 1 inch inferior. And it's too much. So he knows I do textbook. That's how I teach textbook. I've always done textbook.
Clinic, they do Gardner way.
Not all clinic. This way, they do. It's all gonna depend, and I'm gonna smack you.
I felt the tension there.
Not all clinic.
Cut it with a knife.
So, but whether you go distal this way, his idea of distal is going posterior this way, and that's this one. And you're
Just
literally,
remember 1 inch
in
distal.
this, you end up behind, so you're going diagonal that way. I've always done textbook, even
I'm
when I was in
surprised he
clinic.
does that, because that, you have to open up the collimation so much more to include the navicular, and he always tells us not to have all that extra empty space, because it's,
But that's
or something.
That's, cause he's actually right here. literally right there. That's his. I've always done textbook. So. And you can even tell them, I've learned textbook. They want to show you a different way to do it. That's fine, because you're going to learn all different types of way to do things.
Mhm.